Thank you. I want to especially thank Sarah, Walt and David for this invitation to come back and see a lot of friends. My talk is going to be nothing as interesting and dramatic as Chris's was. This will be a little bit dry, and it's really a change in tone. I have a number of conflicts of interest, which I'll go through quickly, because I don't want to waste the time on them. But my wife is also, with Tom Walliver, they put together a company that does testing for glycemic index, and I have to declare that I've retracted a nut paper from Diabetes Care from 2011, which we hope to resubmit after redoing some of the stats. So common ways of reducing, as I say, this is a change of pace, common ways of reducing postprandial glycemia. In other words, if we believe that raised blood glucose is a problem, how can we modulate that? We can improve blood glucose dispersal. There are various ways of doing this, tissue sensitization with biguanides, etc. In the old days, thiazolidinediones. We can increase glucose losses. The SGL2 inhibitors that are being used now will actually get you to leak glucose from the urine, so you can get rid of your glucose that way. They also actually reduce glucose absorption to some extent, and that's the SGLT1. And reducing the amount of bad carbohydrates, and altering the carbohydrate quality to a lenti or slow-release form. Those are the sorts of ways that I think we've got. If we look at reducing the amount of dietary carbohydrate, let me sort of reanalyze the Predimed story for you and say that I thought Miguel did a tremendous job in showing us how you can displace white bread with nuts and olive oil and get these particular advantages, very nice advantages in terms of cardiovascular disease, especially stroke, which he's already shown. And I think Walt, Simon, and Frank and the others have done a tremendous job looking at in the nurses' study, the deciles of increased protein and fat intake, and looking at the contrast between animal and vegetable intake. So at the highest levels of protein and fat intake, it's the plant foods that show you the advantage, in others with a 30% reduction in cardiovascular disease. And the results are even more impressive when one looks at the diabetes scenario under these situations. So I think, again, reducing what I think Walt has developed very nicely, the glycemic index and load concept, in other words, the glycemic index times the carbohydrate, is of importance. And it's important to what you swap your carbohydrate with. The Jacobson study looked at a large group of men and women, large cohort perspectives, Danish perspective study, and showed that 5% of energy from saturated fat exchanged with a high glycemic index carbohydrate showed that the high glycemic index food obviously increased, well, not obviously, but did increase myocardial infarction risk. On the other hand, if you swapped the saturated fat with low glycemic index carbohydrate, you were on the beneficial side. So a low saturated fat may not be so bad if you use intermediate or higher glycemic index carbohydrates. So it really depends on what the comparator is, and I think this is shown quite nicely here by one of Darish's publications looking at exchange of carbohydrate replacing saturated fat. And as you can see, basically things are really mostly crossing the unity line. So there's not a great deal of change if you use high or medium glycemic index with saturated fat. So we're really talking about low glycemic index carbohydrates as the things of interest if one's wanting to go to health. And so that's where we're really thinking of how you slow carbohydrate absorption rather than just reducing the amount. You may want to reduce the amount of bad carbs and also have slowly released carbohydrates in your diet. Acarbose is the sort of poster child we use, the drug that we use to illustrate the point. But you could do it with viscous fibers, and we believe low glycemic index foods will all slow the digestion of carbohydrate in the gastrointestinal tract producing flatter postprandial glycemia if one takes the carbohydrate as lenti or slow release. And you can do this with guar, as shown at the top. You can lower the blood glucose response with the guar crisp bread. If you add acarbose, if you give acarbose, you can do the same thing. And if you add a guar crisp bread with acarbose, you can really knock the postprandial glycemia down. So there are ways in which we can reduce this. The acarbose study showed reductions in cardiovascular events in high-risk individuals, almost a 50% reduction, and a reduction in new onset hypertension. So I think that's the sort of the mechanism. It seems to work better in women and men. In the Liverseq meta-analysis, you can see in the top third that women seem to do quite well when they have reduced glycemic load in their as their dietary carbohydrate. They have if they have high glycemic load, you can see they do worse. Men do a little bit worse, and the bottom diamond shows that if you combine men and women, in general you do worse on high glycemic load diets. And Arash did the same thing for cardiovascular risk in our group, Arash Mirahimi. Again, the same sort of pattern, women doing worse, men doing certainly not better, and combining the two, they do badly with cardiovascular disease if you take a high glycemic load diet. So who benefits? Well, we looked at a study that we did reducing both the load and the glycemic, the carbohydrate content and the glycemic index. In other words, a low glycemic load diet. And as you can see, if you've got a baseline blood pressure less than 130, you don't really, it doesn't make any difference. And if it's greater than 130, it does make a difference. Hypertension has long been known to be related to insulin resistance. It's part of the metabolic syndrome. So, in other words, if you're on the way to the metabolic syndrome, a low glycemic load will definitely benefit, where you may not be able to show the difference if people have no evidence of the metabolic syndrome. And the same thing happens if you look at waist to height. If you look to waist independently, that will be so too. You can see that if you're in the lower half of the group of type 2 diabetics we looked at, as people who are pretty well normal or nearer normal in terms of waist to height, you make no difference what your load is. But if your waist to height is high, you've got a high waist, then there's a difference. And those are insulin resistance, obviously, is a factor there. Cardiovascular risk as such, too, if you look at a Framingham risk score, people who've got the lower end of the Framingham risk score seem not to do so well, or don't make any difference, whether you give high fiber as such or low glycemic index, they're the same. I have to say that it's a high fiber diet that we're giving as the control, a high cereal fiber diet. So that in turn has its own benefits. On the other hand, if you've got high risk score, then you will do better if you have a low load. And I think that goes along with the sort of responses that David Ludwig has shown nicely in terms of weight loss. On the left, you can see those who have normal postprandial insulin responses, and on the right, you can see the high. Am I at the right? Yes, I'm at the right. Postprandial responses. So those over 57.5. That's where giving a low glycemic load diet actually helps, rather than a low fat diet in terms of weight loss. And again, going back to our Harvard group, shown nicely here the effects of tertiles of glycemic load on the side, and at the bottom BMI. And all of you here, as I always say, and everyone says, and we all agree, you're all less than 23, so the glycemic index, the talk I'm giving, doesn't really matter. As you can see, it doesn't matter what your tertile of glycemic load is, you'll still live long and prosper. The same thing was found by Fourier-Brigenti's group. They did a cross-sectional study looking at NAFL, at fatty liver, and they showed, and you can see the insulin-resistant group are the only group where a high glycemic index diet is associated with increased liver fat. If you're insulin sensitive, it doesn't seem to matter what sort of diet you're on. And finally, Simon Liu's assessment of the rise with CRP with glycemic load, you can see that that rise in CRP really only happens appreciably when your BMI is over 25. So in other words, fatter people do worse and do better when you reduce their glycemic load. So I hope I'm on time. Slowing carbohydrate absorption, low glycemic index diets, low glycemic load diets, acarbose, viscous fiber, is likely to be most effective in those with the greatest insulin resistance and cardiovascular risk. And one just questions whether this conclusion may be valid for other treatment approaches. Thank you.
Thank you. Well, I have the unenviable task of being the last speaker before an Oldways meal. So I will try to give a fast talk about slow carbohydrate. So the first law of thermodynamics, and I have a light here that shows me about timing.
Yes, right here.
There. First law of thermodynamics says, of course, that energy can neither be created nor destroyed. And don't worry, I'm not going to argue that that is wrong. And so to apply this to humans or any living system is the familiar equation, calorie intake minus expenditure equals calories stored. And in humans, we store most of our calories as fat, and so we can change that to functionally to adiposity. According to the conventional interpretation of this law, obesity is a voluntary failure in the control of their energy control of energy intake. In other words, in an environment with ubiquitous tasty foods, we easily overconsume, and we have inadequate opportunities to burn off those calories. So they build up as circulating metabolic fuels, calorie-rich substances in the blood, glucose, lipids, and others that are then forced into fat cells, making the fat cells anabolic or grow. So from this perspective, the simple solution, we've heard it 1,000 times. Eat less and move more. But we have to confront one very uncomfortable fact, which is that very few people can successfully maintain even modest weight loss over the long term. This is a nationally representative study. 1 in 6 self-report that they kept off 10% of their weight over a year. This is undoubtedly an overestimate because people are optimistic in these self-assessments. And that 10% is only a modest degree of the actual magnitude of overweight for these responding individuals. In pediatrics, we've seen, if not a more bleak situation, with most interventions marked by small changes in weight, or adiposity, and substantial relapse. So we have to ask, why is this paradigm, it's so simple, just eat a little less and move a little more, failed in practice? Well, I think one reason is that it disregards a fundamental biological fact known in the research laboratory for decades, if not a century, which is that body weight is under biological control through a series of overlapping neurological, hormonal, and other signals in the body connecting organs throughout the body, importantly including the fat cells. So we know that when weight is reduced, whether it is for somebody who starts out lean or somebody who starts out with a high BMI, when weight is reduced by underfeeding, hunger goes up and energy expenditure goes down, metabolism slows. And that's going to push body weight back down to baseline. But the opposite also happens. When an individual in an overfeeding study is force-fed, they'll gain weight, of course, but they're just as miserable as people in the underfeeding studies. They lose all interest in food, appetite vanishes, and energy expenditure increases in the body's attempt to burn off those extra calories. Once the protocol ends, the subjects are relieved and their weight typically comes right back down to baseline, giving rise to this notion of a body weight set point. But there's one intuitively concerning issue with this notion. it raises two unanswered questions. Why is this set point, which presumably has some genetic determination, why is it climbing up among genetically stable populations? Most importantly, what can we do about it? So according to an alternative paradigm which does not violate the law of thermodynamics, this equation still applies, but we've had the arrows in the wrong direction. Our assumptions about causal direction have been wrong. And instead, the arrows should be going from right to left. Again, this still will satisfy physics, but it puts the emphasis on the fat cells. Something has triggered our fat cells to suck up and store too many calories. So instead of having too many calories circulating in the bloodstream, there are actually too few. The brain recognizes that as a metabolic problem, increasing hunger and leading us to overeat. And at the same time, it does other measures, it enacts other biological measures to help us conserve calories. We feel fatigued and less likely to engage in physical activity, and our resting energy expenditure declines. Our muscular efficiency improves. So from this perspective, if this is right, then the recommendation to eat less and move more is not only misguided, it's doomed to fail, because it actually makes the fundamental problem worse. The fundamental problem being not too many calories in the fat, but too few calories in the bloodstream available for the rest of the body. So what could be triggering our fat cells into this excessively anabolic state? Well, an obvious culprit is insulin. Insulin is the ultimate anabolic hormone. It's fat cell fertilizer. An individual with diabetes, type 1 diabetes, given too much insulin will invariably gain weight. And given too little insulin will invariably lose weight. This is absolutely demonstrable in animal studies, clinical trials, observational studies, mechanisms. And what could be raising insulin? Well, an obvious culprit here is all of the increased carbohydrate, and a particular kind of carbohydrate that has flooded our diet during the focus on the low-fat diet years. Both, as David Jenkins spoke about, both the total amount of carbohydrate, but also glycemic index, which together make for the glycemic load, which best predicts how blood sugar will actually change after a meal. So what happens after meals with different glycemic indices and load? In this study, we looked at 12 obese adolescents on 3 different days, giving them meals with identical calories. But in one case, the meal had a lot of processed carbohydrate, instant oatmeal, versus steel-cut oats, less processed, slower digesting, versus a vegetable omelet with fruit that had actually even less carbohydrate, no grains. And we saw, as expected, that insulin, same number of calories, but that high glycemic load meal produced about twice as much insulin compared to the medium glycemic meal, and 4 times as much insulin, at least area under the curve, compared to the low. And that insulin is going to be driving calories into storage, importantly, into fat cells. So after that surge in blood sugar, you can see in the yellow curve, blood sugar comes down and then heads into a relatively hypoglycemic range a few hours later. But we've got a double whammy, because fatty acids, that's ultimately our most potent fuel, that becomes suppressed during the postprandial period, between 3 and 4 hours. So they're both suppressed. And the brain perceives that as a threat, and it launches a countermeasures, which in this case is the secretion of stress hormones. So epinephrine or adrenaline surges after a high glycemic load meal, same calories, but very different hormonal and metabolic states. And when we gave subjects free access to food, they ate 700 or 800 calories more. So same calories, but very different biological states. What's happening in the brain at that time? In a second study, we looked at 12 men. This was a double-blind crossover study, so neither the investigator nor the participant knew what they were consuming. We gave them 2 milkshakes, same protein, fat, and carbohydrate, differing only in the glycemic index of that carbohydrate. And then we looked at blood sugar and, as expected, saw that surge in blood sugar and then a drop-off. At 4 hours later, hunger was greater after the high glycemic index milkshake. And then we conducted a brain imaging study. No, it's not just the food industry that uses these to figure out how to trick us. And this represents the differences between those two meals. We saw one area that lit up in all subjects. I've actually never seen that in a study I've done before. Usually, you're lucky if 8 people go in one direction and 1 or 2 go in the other. In this case, everybody had the same. So we had enormously high statistical confidence in the result. That area that lit up, well, I didn't know what it was either until I spoke to my collaborators. That's the nucleus accumbens, ground zero for addiction. Heroin, cocaine, alcoholism. It's the reward and pleasure center, saliency and reward. So it's one thing to be hungry 4 hours after eating that 500-calorie pastry. But if your reward and motivation center lights up too, it's going to be enormously difficult to control behavior later. And then in the last study I'd like to present, we're looking at the other end of the energy balance equation. We gave 21 young adults who'd been weight stable but with high BMI. We fed them everything they consumed for a 7-month period. We first brought their weight down by 10 to 15%, which would put them under metabolic stress, increased hunger, lower metabolic rate. And then we put them for a month at a time on one of 3 diets, a conventional low-fat diet, which most of the carbohydrate, although it was high glycemic index, it was whole grains, processed, but it was whole grains. And on the other end, we had an Atkins-type, very low carbohydrate diet. And in the middle, we had a sort of a classic Mediterranean diet that had an emphasis on less processed carbohydrate. And we saw that with weight loss on the low-fat diet, now everybody gets each diet for a month, so it was randomized. The low-fat group, LF, on the slide, experienced the expected large decrease in energy expenditure. This was done by stable isotopes, so it's a very precise measure. More than 400 calories a day, metabolism slowing down. That person's going to be feeling cold, tired, hungry, and probably not wanting to stay on that diet. On the low-carb diet, there was no decrease in energy expenditure at all. Completely ablated that decrease. That difference of 325 calories is actually the calorie gap that's responsible for the whole obesity epidemic. So at least according to this model, and I think that I'm not trying to make a direct translation, but if this effect were permanent, you could postulate an obesity epidemic without any change in energy intake, just through energy expenditure. We know that there has also been changes in energy intake, so the combination would be particularly large. The low glycemic index Mediterranean diet was in the middle. There was a couple of potential downsides to the low-carb diet. We saw cortisol level going up, and we don't know yet the implications of that to body composition or risk, so we'll need longer-term studies. And lastly, I'd like to comment on the long-term behavioral studies. We have this notion that diet doesn't matter. Any diet works as long as you follow it, and one study that has given rise to that notion is the pounds lost study. 800 adults assigned to diets that differ, in theory, a lot in carbohydrate, fat, and protein. After 2 years, no difference in any diet group. But these studies typically have a major drawback, which is that they fail to reach the nutrient targets. In this case, the reported difference in fat was a mere 9% and protein 5%. But even these small differences were likely overestimated because they're self-report. If you hire people to join a study, if you recruit people to join a study, you tell them to eat a low-fat diet, you pay them for complying with your study, and then you ask them what you're eating, what are they going to say? So it's a social desirability bias. When you look at the process measures, there was no difference in triglycerides, a sensitive measure of carbohydrate. No difference in nitrogen excretion, which is a sensitive measure of protein, and only a very small difference in RQ. There have been a few studies that do it right, and Meyer was involved in this one, the direct study, in which This was done in a nuclear power plant, if I'm not mistaken, in Israel, where you kind of got locked down for the day. And in Israel, you ate your main meal typically at lunch, midday. So they could control about 50% of what was actually going into the mouth. Now, they didn't get perfect compliance, but even with this improved design, they saw the low-carb diet produced a rapid and sustained, a rapid decline in body weight with some weight gain. The Mediterranean diet in the yellow was more of the tortoise than the hare, a little slower weight loss, but it caught up, and the low-fat diet did least well. So just bringing the model together, in addition to dietary carbohydrate, I think there are other aspects of our diet that could be overstimulating fat cells. Protein in excessive amount absolutely can do it. It releases insulin. Animal proteins seem to release more insulin than vegetable proteins due to their lysine and arginine ratios. And other aspects of our environment. So, another pyramid to look at. Let me just summarize that the conventional approach to weight loss, the calorie-restricted diet, has had poor efficacy in an environment with unlimited food availability. An alternative approach aims not to restrict calories, creating a battle with biology, but instead to produce weight loss under ad libitum conditions by altering our biology, specifically our fat cells. We have to interpret the behavioral studies carefully because of poor compliance. We need future research to compare strategies that are focused on dietary composition versus calorie restriction. And in my last slide, I would just like to mention that although these thoughts may seem a bit provocative, I'll argue that they're not new. The editors of a leading medical journal wrote that when we read the fat woman has the remedy in her own hands, or rather between her own teeth, there is an implication that obesity is merely the result of unsatisfactory dietary bookkeeping. Although logic suggests that body fat may be decreased by altering the balance sheet through diminished intake or increased output or both, the problem is not really so simple and uncomplicated as it is pictured. These words were written by the editors of JAMA in 1924. And I'd like to just announce that I'll be summarizing these concepts for the public in my forthcoming book, Always Hungry. Thank you very much for your attention.
Very much appreciate both of your talks. I guess I think a lot, I think almost entirely about translating things to a general interest magazine audience. And so when I look, I was just looking at the Harvard School of Public Health values on Glycemic Index. You see a lot of things in there that could easily be confusing, I think, to your average, everyday consumer of food. Like that quinoa has a higher glycemic index than ice cream. So how, do you consider this approach to this way of thinking to be something that is for the general public or more for the policy makers, the experts in considering things? How prime time is glycemic index oriented eating in your minds?
And Mars bars are low too. So, there are many things that are low. And none of us, I think, would want that to be the sole criterion. Just one of the many criteria that one uses in terms of assessing whether a food's good. So if a food looks bad, I'm not going to say it smells bad, it probably smells good, but has a low glycemic index, that still is a bad food. If, on the other hand, the food looks pretty good and has a higher glycemic index, that's probably still good overall. So what one's saying is, it may help you make a decision that you perhaps don't want to eat something that looks bad and has a high glycemic index.
Just comment on that a little bit. That actually I've been in general not strongly in favor of adding glycemic index values to foods. That it can get people to focus just on one number and make decisions that don't make sense. But my position was a little bit tempered a couple of years ago when we were doing a study in India and wanted to have a really healthy rice compared to a usual refined white rice. And so we thought that parboiled rice would be good because that lowers the glycemic index. And we thought whole grain brown rice would be good. And so Uncle Ben had a parboiled brown rice that we got for the study. But we did take the trouble to test its glycemic index, and it was extremely high. And I know something about nutrition, and that just totally fooled me. And when we went back to Uncle Ben's, they said, "Oh yes, we really used a special strain of rice that had a very high glycemic index to shorten the cooking time." And people would have been quite misled if they were really trying to make a healthy choice and had some pretty good nutritional knowledge. They would have been misled by that product. So I don't know what the right answer is, but there does seem to be a place for some of this information. Different consumers want different levels of detail. Some people just want a red light or a green light. Other people really want to know more, and I think we're back to no size fits all. But David may have a thought on that.
I'd just say that there's, sometimes this is used as a criticism against the notion of glycemic index or low, that ice cream is lower than potato. But no one factor can ever define a healthful diet. That's a basic premise here. Not even the most ardent low-fat advocate would say drink Coca-Cola all day long because it's got 0 grams of fat. So as a guide to consumer choice, I think it can be useful, although I'm personally not I think I'm kind of in the middle ground, perhaps, as you would be about that number. I think the bottom line is the practical implications, which you don't need a number for. We've got to reduce consumption of the highly processed carbohydrates that have flooded the diet. Those release more insulin calorie for calorie than anything else. And if we did that, we would, by itself, probably take care of 50% of nutrition-related chronic disease.
I guess just my thought on that is how do you do that without, like, it came up earlier, kind of opening the floodgates for these loopholes for what is not included in things that flood your blood with glucose, and that we also know would be bad for you, by introducing this paradigm, this way of thinking as someone's primary approach. I mean, just because we know people tend to take simplistic views and they don't, they're looking for a couple rules that can inform them as opposed to incorporating every single way of thinking about food.
Well, I mean, just going back to the paradigm I suggested, I'm trying to make a provocative statement, but I've actually convinced myself it's true. That overeating isn't the real problem. I know that we focused on this notion of sugar, salt, and fat, and yes, those foods are very tasty, but tastiness is not an inherent, palatability is not an inherent aspect of food. It's a biological response. It's simple to tell. Before Thanksgiving coming up, you've not eaten anything all day in anticipation of the dinner. That first bite of buttery stuffing, it's going to taste great. But at the end of the meal, after eating too much dessert and too much alcohol, what's the palatability of that stuffing? It's going to be very low. In fact, foods that we initially react negatively to, like beer. Remember your first sip of beer? That was probably very unpleasant. But you come to associate the biological rewards of the beer with its taste. And so it becomes tasty, and as does coffee, another very bitter thing. We associate the pleasure of processed foods. It's not the taste itself. When people come from Africa, the rare patient I get now who hasn't been exposed to Western diet, and they eat some of these processed foods, they find it repulsive, actually, like heartburn. But you come to associate the biological rewards, which is that flood of sugar into the body. So I think that's really where we need to focus. That if you overeat these foods, you're going to set up an addictive cycle of high insulin, low blood sugar, and cravings with your brain area. If you overeat olive oil, you're going to get biological pushback. First, you'll feel full, and then you'll feel nauseated, and you will not be interested in food for a long time. I think that's how I think it's a self-correcting mechanism that doesn't require numbers.
should open up the questions here to the audience. We are a little behind schedule, but I think we can squeeze
I
in.
just wanted to say one thing about you talk about the individual effects of one food here and one food there, but people eat food in combinations, and I think that's the most important thing to remember, is that you're eating an entire meal and you may not get that effect. Because you were talking, how do we grab that microphone? Yeah, how do we deal with people wanting to know the scores on each food? We don't have to, right?
Yeah, well, just to emphasize that, so your point is right, that if you eat, a bagel with peanut butter, you're going to have a lower response to that bagel than if you ate it by yourself. Hopefully you're eating maybe a half a bagel with peanut butter rather than the whole bagel. But all of the studies that I presented and the ones that you've heard about are mixed meals, either interventional studies or observational studies where people are actually eating these things in real life. So the numbers, even though they shift relatively, a bagel's always going to be higher than a bowl of beans. And that's going to translate over time into either pushing you in the right biological direction or the wrong one.
Got a mic here? Well, first, to both Davids, thank you for those really brilliant lectures. They were really inspiring to me. Just one point, though, that I want to make, which is that it gets, we're talking about finding common ground here. I think we would all agree that low glycemic index foods are optimal. What concerns me is in both studies David Jenkins and David Ludwig presented were set up this kind of straw man between low-fat versus low glycemic index foods, as though they're somehow mutually exclusive. What happens in both the studies the studies that you both cited were that the fat was replaced with sugar, and that's never a good choice. And so it makes it look like low-fat foods are not as good when in fact they're really high-sugar foods. We found that when you reduce the glycemic index and less fat, that you get an optimal benefit. And I'm wondering, and now that's true of the SHI studies and others that you cited as well. Do either of you have any comments on that?
I think that's absolutely true. I think you can have a very good, healthy, low glycemic index diet, which is higher in carbohydrate. And in fact, one of the reasons why we were interested in the beginning at looking at this particular aspect of carbohydrate, because we saw that carbohydrates, as they were not particularly desirable in the diet, and we were afraid, in anticipation, that shortly there would be a big backlash against the bad sort of carbohydrates in the diet, and so we wanted to actually classify them so that the healthy, the useful carbohydrate foods could still be preserved.
One point of agreement and one point of disagreement. The point, I guess that's the process of consensus. Identify what we disagree on. So we don't know what the optimal macronutrient ratio is. And as you decrease fat intake, then the glycemic index becomes more and more important because you're just eating much more carbohydrate. And as many people have discussed today, including Chris, Garner, importantly, there may be variation in that some people do pretty well on a low-fat diet, and other people, especially those with metabolic problems, like much of the country, may need a substantial decline in total amount. That said, I disagree that the differences that we've discussed are a result of trading fat for sugar, which actually used to be argued as a good trade-off. But the first study I showed you, people used to think that sugar was better than fat. The first study I showed you, the pediatric study, had exactly the same amount of sugar in both the instant oatmeal group and the seal cut group. The differences that you saw were entirely due to the differences in digestion rates. And then the third group, which had no starch at all, seemed to show the best result. So many of these studies make substitutions for grain and not sugar with fat.
But just as a follow-up, the grain that they substitute is generally high glycemic index grain as opposed to low glycemic index grain. And wouldn't it be more optimal to look at foods that are both low in fat because it's so dense in calories and low in glycemic index? In those studies, I haven't seen you present.
I agree with you that is an interesting. Those are modeling. In fact, the Jacobson study in AJCN that David showed demonstrates exactly that. That if you're going to If you're going to trade saturated fat for, if you trade saturated fat for high glycemic carbohydrates, you're worse off. And if you trade them for low glycemic index carbohydrates, you're better off. But keep in mind what the American public is doing. You know, we are not mostly eating very low glycemic grains, legumes, and the like. We're eating a very processed carbohydrate, and one way of reducing that, not the only way, is to increase fat. That's a very tasty, quick, partial solution. And then let's go the rest of the way by focusing on less processed carbohydrates.
Just to, of course, add to that, the type of fat makes a huge difference as well. So we've got to keep an eye on both the type of fat and the type of carbohydrate. One more, David, and then maybe we should stop for lunch.
Yes.
Just another, I think I still got my lot of way.
Yes.
On? Good, thank you. So, David L., this is directed to you. That 325 calorie depression, essentially related to the weight loss, and there was compensation for that with the low-carb diet. Couple questions related to that. You referred to some potential disadvantages of high animal protein intake in that group, and so one question is, are you looking toward a study David J. published on the Eco-Atkins, which essentially was a low carbohydrate but plant-based diet, and that would seem an obvious comparison and fodder for future study. And then the related question is, do you have any data on body composition? I'm wondering what the effects on lean body mass were with that intervention and how that figured into the change in essentially resting energy expenditure.
Yeah, on the first point, we designed that study, the JAMA study 2012, not to be unfair to the low-fat group. We didn't dump in a lot of sugar, but we used whole grains, and that group actually had more fiber than any other group. We also didn't want to bias the low-fat group, the low-carb group. In other words, we didn't want to design the best possible low-carb diet. We wanted to do something that looked like Atkins recommended. The name of our study was Popular Diet Study, to try to achieve patterns that reflect what were actually happening in the public. You raise an interesting question. Could we have our low-carb cake and eat it too if we went with a Eco-Atkins, or I like to call it an Eco-Keto? Take your pick. I think that's a great study to do. As to body composition, that's probably now the most interesting and provocative question right now. We saw international headlines. I think Dean Ornish might have mentioned this from the Hall study. That was a 6-day study. And I believe they weren't in fact balanced yet. If you take people who are eating a high-carb diet and you suddenly increase their fat intake, it's going to take a while to shift. I believe that when the long-term studies come out, including, maybe Meyer can comment on at some point, Central, which is in the clinical trials registry and is completed. And it's a very impressive study of dietary composition with a feeding design on body composition. I think we're going to have a definitive answer, and I believe that Kevin Hall will be surprised.